Good afternoon, everyone. I thank the Indian Heart Rhythm Society for this opportunity to present at this unique joint session with the European Heart Rhythm Association. I shall be speaking about the role of artificial intelligence in the diagnosis management of sudden cardiac arrest. The objectives of my talk are essentially to discuss the scope of the problem, the challenges before us, and how artificial intelligence may aid in recognition, prevention, and optimization of resources for the management of sudden cardiac arrest. Implementation of the real-world management of these conditions will also be discussed in brief. In a questionnaire which was completed by medical trainees from 8 medical colleges, comprising of nearly around 22,724 people being evaluated, nearly 10.3% deaths were adjudicated as sudden cardiac deaths. The age profile of these patients were 5 to 8 years younger compared to the Western Hemisphere. Among 254 patients admitted as cardiac arrest to CMC Vellore, 73% of them had additional in-hospital cardiac arrests. Most of them were pulseless electrical activity, and survival to hospital admission was 30%, where survival to discharge was just 10%. In the out-hospital cardiac arrests, 7.4% only received bystander resuscitation. As we all know, the proportion of people with comorbidities having sudden cardiac arrest is large. However, in terms of absolute numbers, it's the general population who's at maximal risk. The reasons for poor survival, amongst others, include an inadequate initial response by people around this patient, the heightened response times of medical personnel, and as we grow older, the increasing number of comorbidities that we have. One of the easiest ways to prevent sudden cardiac arrest is to be able to preempt it, and the evaluation or assessment of ejection fraction remains a very powerful tool in the same. The use of machine learning algorithms to be able to predict the ejection fraction of a patient from a 12-lead ECG is one of those algorithms that can help us diagnose patients at risk of a sudden cardiac arrest. Additionally, this algorithm also predicts a future decline in ejection fraction if the current echocardiographic value is normal. Patients with hypertrophic cardiomyopathy can also be detected using a convolutional neural network via the use of a 12-lead ECG. It was possible to diagnose HCM with the negative predictive value of 99%. So ECGs could be ruled out as having HCM or not. Apparently normal looking ECGs would also be diagnosed correctly using this algorithm, and the probability of having an abnormal ECG after myectomy showed an appropriate decline. Review of data sets to be able to diagnose ICD therapy and abnormal heart rhythms is also possible in these patients, as is the automated extraction using natural language processing of factors that put a patient at higher risk of sudden cardiac arrest in HCM. Using home-based speakers or smartphones, it was possible to diagnose agonal breathing and other sounds which were secondary to patients having a sudden cardiac arrest. And over various iterations, the false positive rate became virtually non-existent. This was evaluated over a variety of vendors and in both males and females. This provides a very powerful tool to be able to diagnose sudden cardiac arrests and contact somebody, either medical personnel or family people around. Diagnosis of an abnormal QT interval is also very useful in predicting arrhythmias, and a machine learning algorithm was able to correlate very well with the diagnosis of abnormal QT intervals as compared to an experienced cardiologist. In addition, the algorithm was also able to diagnose a channelopathy-based long QT syndrome even when the ECG was apparently normal. Coming from diagnosing patients at risk to the use of AI in ensuring adequate allocation of resources. In this study performed using the Fireman's database in Japan, it was possible by a machine learning algorithm to predict whether a particular area would have a spike in cases of sudden cardiac arrest based on meteorological variables. So availability of similar algorithms for various geographical locations could help in better allocation of limited resources. Similarly, on the emergency call numbers, ML algorithms did well in being able to diagnose whether the distress calls were for patients having outside hospital cardiac arrest or not. The algorithm was able to do better than the human dispatcher who was receiving the call, but the under-reliance of the human dispatcher on the same prevented the algorithm from showing significant clinical benefits. This is now being evaluated in a more formal manner in the ASSIST protocol in UK. For patients within the hospital too, evaluation and assessment of various vitals and other variables can help create machine learning models to identify patients who are at risk of sudden cardiac arrest, as well as predict the neurological outcome for patients who are having sudden cardiac arrest in an outside hospital setting. Track and trigger systems, which have been traditionally used to diagnose patients at risk of sudden cardiac arrest using single vitals or multiple vitals, have now been enhanced by the use of machine learning algorithms to be able to provide similar or even better results at lower alarms per patient per hour. Presumably, this is because of a better understanding of the interrelation between the various vitals that comprise the trigger and track systems. Addition of learning features within these algorithms stand to make these even more powerful, thereby improving the efficacy of the system as a whole in identifying patients and setting off alarms for patients at risk. Assessment of the 12-lead ECG can also predict cardiac arrest in hospitalized patients in this study by Kwan et al. This algorithm could predict sudden cardiac arrest within 24 hours of the ECG being taken. So these are again important algorithms which could help shape practice to aid in allocation of resources and intervene ahead of time in patients who are at higher risk, thereby providing them with a higher grade of care or more nursing care in order to enable appropriate interventions. The CRT and the defibrillator components of the device have been through time very useful in improving outcomes. Now with the use of machine learning algorithms, we can go beyond the LBBB and the QRS duration greater than 150 milliseconds in identifying those patients using QRS waveforms run through a machine learning algorithm to look at outcomes of CRT implantation. This risk calculator is available at this link and could prove useful to identify patients who could do well with the use of CRT. In patients who had ischemic cardiomyopathy and ejection fraction less than 40%, evaluation of the action potential or monophasic action potential using the Boston Scientific MAP catheter, and following them up over a period of time, was able to figure out certain action potential phenotypes that were at higher risk for developing cardiac arrest. This, when evaluated in a larger cohort, could prove very useful in identifying patients at a higher risk of cardiac arrest in times to come. As with every literature that is available to us, assessment of the validity of the same is important. We have to evaluate the model performance, whether certain subgroups where we are planning to apply it onto are indeed evaluated, and the models have to be validated across external populations. Updation of the model is critical, and use of these models without appropriate safety nets may prove to be challenging. Oversight on AI from regulatory bodies as well as from insurance companies is very important. In the future, we hope to integrate multiple modalities like imaging, ECGs, echoes, in order to aid in improvement in prediction, as well as tailor a procedure if needed to the anatomy and the physiology of the patient. In India, the National Digital Health Blueprint. In Singapore, Apple and the Singapore government, the National Digital Health Mission, as well as South Korean's clearance to the WUNO algorithm for cardiac arrest prevention are all steps in the forward direction to help prevent sudden cardiac arrest and better manage these patients. The SafeHeart mHealth platform is attempting to aid with the use of ML algorithms our prediction of patients who would be good candidates for sudden cardiac arrest. The results of this are awaited. Improvement in the hardware used to record something as simple as an ECG can help provide data which can then be processed using AI and ML algorithms to give you a virtual bouquet of possibilities for a single ECG. Trust in AI, however, remains challenging, and it's a work in progress. The mind is a high resistance pathway, and just logic may not help us change our behavior. Hence, it is important to incorporate other incentives, mainly social incentives, by making our activities witnessable and thereby allowing us to model our behaviors on others. In the meanwhile, given our infrastructure, it is important that we rely upon the one thing that is definitely known to improve outcomes, namely bystander CPR, and allocate and concentrate our resources in ensuring that a large population knows about CPR and is capable enough to provide it. Increasing penetration of defibrillators, automated external ones at that, and teaching people how to use them is very crucial in ensuring a potential herd immunity situation. In summary, therefore, sudden cardiac arrest is a challenge of immense magnitude. AI can aid in the early detection of at-risk group as well as early detection of the condition. It's important that we allocate our resources wisely, and AI can help in it. It's important that we are able to predict in-hospital cardiac arrest so as to treat our patients better. Acceptability remains still a challenge, and bystander CPR still remains a very viable and important intervention in the management of these patients. Thank you for your patient hearing. I would love to take some questions.